role of physician advisor is an interesting one. It's something that can be molded to the needs of that particular hospital. The primary responsibility of any physician advisor is to manage utilization review, ensuring compliance with medical necessity guidelines, both for commercial insurance and for Medicare and Medicaid. So physician advisors at most facilities perform peer-to-peer discussions in cases of insurance denial for inpatient level of care requests, but all physician advisors are going to be doing utilization management. But at AGH, the physician advisors have a lot of responsibilities in addition to what I just discussed, which is utilization management. At AGH, the physician advisors work closely with the C-suite and kind of provide that on-the-ground look at hospital operations. So multiple responsibilities for an advisor here at AGH, and I won't go through them all, but some of them are to be involved in interdisciplinary team rounds. There are rounds on all of the floors of the hospital that involve multiple individuals, including nursing staff, case management, and social work, and oftentimes the physicians themselves. And what we do on these rounds is we discuss all of the patients on that unit and what is where they are in the progression of care. Are they close to discharge? What is their discharge disposition expected to be? What do we as a team need to do to ensure that when that patient is medically ready for discharge, we have everything in place to have them discharged to home, with home health care needs, to have them discharged to a skilled nursing facility, LTAC, etc. Every Wednesday at noon, we are involved in complex care calls. Because AGH has a lot of complex dispositions, we discuss every patient that's been in the hospital for over 20 days that does not have a discharge plan in place, or any patient even that's less than 20 days that is expected to be difficult to find a discharge disposition. So we are meeting with the CMO, the case management leadership, social work leadership, physician advisors are all getting together and discussing these cases to ensure that we're all on the same page to determine discharge disposition. Process improvement, which is, like I had already discussed, but our physician advisors, they have such an on-the-ground look, especially through these interdisciplinary team rounds, that they can identify process breakdowns before those process breakdowns show up in our data, right? So they might notice that phlebotomy is delayed before we find out that phlebotomy is delayed through data review. So finding these things and just learning that, hey, for the last 3 days, we've been told, there's delays in echo or there's delays in MRI. We can kind of intervene earlier because they have that on the ground look. And then our physician advisors are also involved in peer-to-peer discussions with insurance companies when there's a post-acute denial, like a skilled nursing facility or LTAC denial. They're very well versed in the criteria required to have an approval for a skilled nursing facility or LTAC, and thus can argue effectively with insurance companies based on those guidelines for why a patient requires that specific disposition or that specific facility. And so I was very involved as a physician advisor in all of these things, which gave me a lot of experience and provided me with the experience I needed to move forward with associate CMO, which I continued to perform physician advisor duties as associate CMO and still do a few days a month as an advisor even today.